Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral, fully occluding dead skin, as you can see, and also impacted earwax. We're just commencing with their left ear first, but do stay tuned in for their right ear because that was a bit more complex. And in the right ear, the patient had been using a Q-tip, what we call a cotton bud in the UK, and they had grazed the floor of the ear canal, so it was a bit bruised in there. There was also a bit of blood in there, and because they had used a Q-tip in that ear, it was a bit more difficult to remove. It was really impacted against their eardrum. So I'm just using microsuction here just to lift the dead skin that's still semi-attached to the canal wall. So we're trying to retract that, elevate that off the canal wall, and I'm just giving it a little wriggle, as you can see. So this dead skin, it had enveloped the wax plug, and because it was still adhered to the canal wall, it was playing tug of war. It was difficult to release the plug. But you may have noticed there that I managed to remove that dead skin. It got suctioned up, and as soon as that occurred, the wax wasn't free and it was easier to remove. If you are a clinical ear care specialist and you are interested in the WAXscope, please do email info@clearwax.co.uk to learn more. So this is the more medial wax. It's just trapped beyond the second bend, and I've managed to again release that and slowly bring it away. And as I did, it's separated in two. I have got a still image of all the wax that I removed, so if you wait till the end of the video, you'll be able to see that. So that's the wax cleared from the patient's left ear. We're just going to get the eardrum in focus. There we are, looks nice and healthy. Got a good light reflex. And now we're going to move on to the patient's right ear, and you'll probably see at the floor of the ear canal it's a bit of hematoma, so a bit of bruising. There is a bit of blood mixed in here. So this initial piece of dead skin came away quite easily, but you can probably see again it's just stained with blood. There's a view just at the top there that you'll see again in a moment. And already you can tell this is a lot deeper, it's a lot more impacted. You can see it's quite matted here as well. So I'm just trying to release the skin again. And by releasing the skin, it's going to help us to free up the wax plug. So I'm just lifting it away from the posterior canal wall. And here it's a bit more stained with blood. This is the anterior canal wall to the right. And once I get this plug of keratin and wax out, you'll have a clearer view of the ear canal itself. And it was also on the right hand side of the ear canal where they had bruised themselves. There's a bit of an abrasion there, a bit of a laceration. So I'm just working about the skin. So I would say all of this wax and keratin, it's probably in the latter third of the ear canal, but we've got such great magnification with the WAXscope, it looks like it's near the entrance. So all this whitish tissue, this is dead skin, so there's a thick blanket of skin here at the roof of the ear canal, and this keratin and wax plug is engulfed by the ear canal. So the ear canal is narrower up to the point where you see the wax, and then it widens, and that's why I'm trying to bring it down through that narrowing so we can remove it. So sometimes you just have to work away with the wax and be patient. It almost felt like a keratosis obturans this. There's probably a high content of keratin to dead skin than wax, but the patient didn't report any pain. There's no global widening of the ear canal, which is a hallmark of keratosis obturans. They did also get water in this ear. They advised that when they were showering, they were trying to clean their ear out. They did really soak it with water, which is not going to help. What the water will do is cause the wax plugs to further expand. So the majority of earwax is made up of dead skin cells, and these dead skin cells are hydrophilic. They have what we call natural moisturizing factors within the skin cells itself, which absorb water. And by absorbing water, they overhydrate these skin cells, then swell, and they can eventually burst. But during that swelling phase, it will increase the size of the wax plug. And of course, water, I've said it many a time in my videos, it can wash away the natural oils and sweats that our ears produce. And these natural oils and sweats are there for a reason. They help to moisturize the skin that lines the ear canal, and it also provides some acidity in the ear to help prevent colonization and reproduction of pathogenic bacteria, which are more neutrophilic, so they operate and breed better around 7 on the pH scale, where the ear is naturally acidic between, say, 5 and 6 pH. So water increases the alkalinity of the ear, and it washes away those natural oils, which means you get very dry, cracked skin, and you're more likely to experience an ear infection. Obviously, fungi also love moist, warm conditions, which, if you have water in the ear, it's again once more the perfect breeding ground. So we're making good progress, but because it is impacted, I just have to work away at it. And you've still got that thick layer of skin at the top. Just need to be careful to avoid the right hand side of the ear canal where there is a bit of bruising there. Don't want to cause the patient any pain. Because it's a bit deep, I resisted the urge to use any manual instruments. When you go deep in the ear, you've got the bony part, it's highly sensitive, and this patient's ear is already traumatized, so I just decided to continue with the microsuction. Sometimes you just have to make slow and steady progress. It's always a nice feeling when you remove a wax plug almost instantaneously, but that's not always the case. And I'd rather spend a bit more time making sure the patient's fine and remove it that way. So again, I'm just going to the floor of the ear canal. I'm lifting all this dead skin. And slowly but surely. It's almost like Jenga. So when you start removing little blocks away, you're actually reducing the size of the wax plug, which can then make it easier to bring through any narrowing, any isthmus that the ear canal may have. Again, you may have seen some stained blood there. The specular size we're using is our size 2, it's our medium size. It's the most common one that we use. It's a 4.25 millimeter internal diameter. And we can start to see the back of the ear canal now as I'm bringing this wax plug down. Again, I'm just giving it a little jiggle, a little wiggle, just trying to separate it. So when someone uses a cotton swab, they really impact the wax plug up against the eardrum, and the deeper parts of the ear. So by manoeuvring the wax plug left to right, up and down, you're just trying to free it. And I said it in a recent video, I'm just really surprised by how much hair actually is within a wax plug. I think with the WAXscope, because of the great level of detail and magnification it provides, I'm really able to see the matrix of the wax plug. So I've just put some medical grade olive oil just to help loosen this, also to get a better suction grip. When you soften the surface, the suction tip is able to get a bit more purchase. I think when I got this piece away, you can see it's the patient can already hear a lot better because we can just see in the distance the top part of the patient's eardrum. So sound is now able to enter the ear and vibrate against the eardrum. I've just gone back to this floor of the ear canal. I had to be careful that there was no underlying pathology like a canal cholesteatoma, because when you get, there's a lot of keratin like you just saw, especially at the floor on the anterior canal wall, you just don't know what's behind that. So there was a point when I cleaned this ear, I was a bit hesitant whether there was a canal cholesteatoma, but it was just trauma caused by the patient and it was all fine. I did have a secondary look with the endoscope as well, just to make sure, and there's no underlying pathology. I just decided to just get, because now that I can visualise this front part of the ear canal, it's a bit more crusted blood. I think I will eventually remove that. So I'm just going to get the wax plug in focus again. And I think this last bit is right up against the eardrum. So again, this little wriggle movement really does help. Just freeze it up. You can see probably 3/4 of the eardrum, There's just some wax impacted on the posterior canal wall. So I'm going to go, I think, here to see if I release this, will it then start releasing the remainder of the wax plug deeper in the ear? Again, we're going to be careful that we don't make contact with the canal wall. I think I'm just going to adjust the focus. So that latter piece of wax is still actually on the eardrum. You may be able to see that, but I think it comes away when I remove this plug. There we are. So the eardrum is fully exposed now. I'm going to just have a quick look, going to get it in focus. Lovely clear view. So there's just a bit of remnants around the edge. I'm just going to mop that up quickly. And there's a little bit on the posterior canal wall, I think, but I think here it's when I've just removed this crusted bit. Just want to make sure that, again, there's nothing underlying here. It's just on the boundary between the cartilage and the bone, so we're at put about a centimetre in the ear canal there. You can see the abrasion at the bottom here, and it really did graze the entire floor. And when you graze the ear like that, you're taking away the top layer of skin, and in fact, in the inner 2/3, you only have that top layer of skin. And what I mean by that is that normal skin has 3 layers. You have your epidermis layer, which is your external, most superficial layer of skin. Then you have your dermis layer, and then you have your hypodermis or subcutaneous layer, which is predominantly made of adipose fatty tissue. Now, whereas the outer third of the ear canal has 3 layers of skin, the inner 2/3, it only has that epidermis. So if you graze that, you're going to expose the underlying periosteum. So periosteum is like a thin sheath membrane that lines the bone, and it supplies the bone with all the blood and nutrients that it needs to repair and grow. So here is where I just wanted to make sure there's no underlying pathology, and it was just grazed. So I was happy with that. And I think I'm going to go back in and just mop up posteriorly. So you've got a great view of the entire eardrum there. So with the WAXscope, we really went for magnification. There's always a trade-off, field of view and magnification. You can't really have both. The endoscope is probably the best instrument to have the right amount of field of view and magnification. But when people use head loops, you just lack the magnification. So that's what I went for. That's all the wax, the dead skin. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. And again, if you are interested in the WAXscope, please do email info@clearwax.co.uk. Thank you, bye.